What's new in indolent lymphoma here at EHA in Stockholm? Well, from my point of view, there are essentially 4 different abstracts which are really relevant and which do have the potential to change our daily care. So what are these? Well, first of all, in follicular lymphoma, this is really a historical presentation which was shown in the presidential symposium. What are the data? Well, this is the first challenge of our cytostatic treatment, first-line follicular lymphoma. And in this large trial with more than 1,000 patients, in fact, our current standard, R-CHOP or BR-RCVP, were compared to a targeted approach, R-square, which is rituximab lenalidomide, and that is the first proof that targeted therapy is as good as our standard of care. Now, will that really change our current practice? Well, at least for first line, I don't think so. Why is that? Well, we do know with chemotherapy, it takes just about 6 months and then patients are done, whereas the targeted approach, in fact, was a longer exposure of about 1.5 years. However, this is definitely strong data to support this becoming a new standard of care in relapsed follicular. What about marginal zone lymphoma? We have little knowledge in marginal zone lymphoma, and in fact most what we are doing, we're taking from the follicular lymphoma world. And at this convention, in fact, Matthias Rummel with his STEER group was the first one who could confirm the benefit of rituximab maintenance in this entity. So in this study, essentially more than 100 patients were induced with bendamustine plus rituximab, the preferred induction so far. And then patients were randomized between observation and 2 years of antibody maintenance. And what are the results? To make a long story short, this is the first proof that maintenance significantly prolongs progression-free survival, hazard ratio of 0.3, which means that you reduce the danger of relapses by about 2/3. Really a major achievement with the potential to change our standards of care. Waldenström, what's new in Waldenström? Well, what we do know, these patients are mostly elderly, they have impaired hematopoietic reserve. So yes, standard of care in first line normally is a smooth, easy-going combination of antibody plus reduced chemotherapy. But what about relapse? In relapse, we do have the registration of the BTK inhibitor ibrutinib, and here an international consortium has presented the first randomized data in favor of that. In relapse Waldenström, patients were randomized between antibody only versus the combination rituximab plus ibrutinib. And outstandingly, the response rate was doubled, PFS significantly improved, and this is really a major impact. And what is interesting, this benefit was independent of the genotype. So applying this combination, you might no more really check for MYD88 and CXCR4. And to finish up, what about mantle cell lymphoma? Mantle cell lymphoma is, let's say, in between the worlds of indolent and aggressive lymphoma. Standard of care in first line still is chemotherapy, but in relapse disease, we know this is becoming more aggressive, and we tend to switch over to targeted approaches. And the preferred ones are probably ibrutinib and lenalidomide rituximab as the most efficient ones. But what happens if these approaches fail? It's fair to say specifically for the early relapses after ibrutinib, we have no real effective treatment to salvage our patients. And this is where a retrospective series of our British colleagues fall in. What they did, they collected data of 20 patients, most of them pre-treated with BTK inhibitor. And what they've seen, just with the well-tolerated venetoclax monotherapy, you're able to achieve responses in 60% of these patients, and even in the ibrutinib pre-treated ones in the range of 40%. So what does that mean in daily care? In my opinion, this is the new standard of care for ibrutinib failures. In fact, we have implemented this policy already for about a year in our own institution and have seen surprisingly really high quality responses in very high risk patients. So that's the news from EHA. I summarize: follicular lymphoma, challenge of chemotherapy; marginal zone lymphoma, the proof of antibody maintenance; Waldenström, we have excellent data on the combination of rituximab plus ibrutinib; and finally, mantle cell lymphoma, now the first proof that we have an effective salvage for patients failing ibrutinib.